Good afternoon and welcome to another episode of Cerebral Angio reading sessions. This patient was referred by an ophthalmologist. He had sudden onset of dimness of vision of the right eye. A routine carotid Doppler evaluation showed this abnormality. There is a focal plaque in the left internal carotid artery causing moderate to severe flow limiting stenosis, and it is reported as 70 to 75% diameter involving the left proximal internal carotid artery. The patient was taken up for a cerebral angiogram to confirm the diagnosis made by Doppler. Now we have Dr. Jayashankar and Dr. Fasal with us. What is the idea of doing the cerebral angiogram? Why should we do cerebral angiogram in this patient? I always tell there are 5 reasons for which the cerebral angiogram should be done. 1, the Doppler has suggested that there is a stenosis. The main idea is to confirm whether it is a stenosis or not. If there is a stenosis, whether there is a superadded plaque, superadded thrombus, whether it's actually a stenosis or something else. So that is the number 1 thing which we want to identify. And DSA gives much more clarity on the images are much more clearer. It is not an indirect image, it is a direct image. You inject contrast and you take a picture. It is not a reconstructed image. Second, if it is a pathology, decide whether it can be treated or not, by whether it needs treatment. Second, how is the brain getting its supply? How is the collaterals? Because if there is a carotid stenosis on one side, we have to find out how the vertebral system is supporting the carotid MCA territory and how is the opposite carotid supplying this ipsilateral territory. And what is the third thing you want to see? What is a future risk? And based on this, you have to come to a conclusion whether what is the risk of the patient having. For example, if there is a good collateral supply from the opposite side, the patient developing a stroke is much lower. Also, the procedure risk also is much lower. Understood? So these are the main findings which you have to find out by doing a digital subtraction angiography. This is the angiogram was done through the radial route. So this is the radial angio. This is the radial artery, and this is the brachial artery, and this is the ulnar artery. Many times the radial artery is of good caliber as seen in this particular patient. So this is a good caliber artery. You can see the sheath here. This is the sheath, end of the sheath. Now the catheter is taken and we'll go to the next picture. So what is this picture? What is this white image? Many times now we see this white image. This is called a road map image. A road map is like when you are driving in a highway, you switch on the light and then you go. So you can see the road as well as what is in front of you. It is not like a blind procedure. It is not like driving in pitch darkness. So when you have a road map image like this, when you move the catheter, you can see the catheter going through this white image. So you can exactly take the catheter into whichever vessel you want without creating damage. So one of the main significant advance in doing a cerebral angiogram is the availability of what is called a road map image. Clear? What do you see here?
You can see the catheter coming from the arch of aorta and hooking the left subclavian.
So this is the catheter. It is hooking the subclavian artery. So this is the subclavian artery, left subclavian, and this vessel is the left vertebral artery. So this is one of the commonest ways in which the left vertebral artery arising from the left subclavian artery. So here you don't have to hook the vertebral artery. Our idea of doing the vertebral angiogram is to find out whether the posterior circulation is supporting the anterior circulation, whether PCOM is patent there or not. So what is this? So the image quality of this vertebral angio is poor because we have injected into the subclavian artery, not directly into the vertebral artery. Now what do you see here?
You can see the left.
What is
vertebral
this?
artery.
This vessel?
Spica. Left
This is
spica.
spica, and this is the left vertebral artery, and this is the
Basilar artery.
and this is the
Scar.
scar. So this is also the scar, and this is the
Right PCA.
and the.
Left PCA.
So most of the vessels are seen, and this faintly seen vessel is the
Ica.
ica on this side. So as is always discussed now, if the pica here is big, the ica is small. And the opposite vertebral is not seen because if you give a very forceful injection, there will be a reflex of contrast into the opposite vertebral. Here it is not seen. And this is the lateral view. So this vessel is the
Vertebral.
vertebral artery, and this is the
Pica.
pica. You can see the pica. See the large pica, and this is the rest of this is the basilar, and this is the posterior cerebral, and the small artery which comes down like this is the scar, and this is the opposite PCA. Clear? Where is the PCOM coming?
PCOM should be going to the front.
PCOM should be coming here. So in the lateral view, if you see a vessel like this coming, that is the PCOM. Here, and you don't see any vessel coming anteriorly. That means PCOM, there is no PCOM here, and PCOM is not supporting the, and you don't see any pile vessels also coming here. So normally the pile vessels should come like this if there is a collateral supply. That also is not seen. So the inference from doing this vertebral angiogram is that the posterior circulation is not supporting the anterior circulation. Now this is what is this?
This is lateral.
This is the lateral. This is the left.
Internal carotid.
We have
common
injected
carotid
from the
artery.
common carotid. So this is, which is this vessel?
Common carotid.
It divides into
Internal carotid.
internal carotid and
External
external carotid. So how do you identify which is external carotid and which is internal carotid?
Siphon, sir. Carotid
Yeah.
siphon.
You can trace it up.
Siphon. And second is internal carotid artery doesn't have any branches in the cervical region, whereas external carotid has lot of branches. See, there are a lot of branches from the external carotid. This is important because if there is a tight stenosis here, sometimes you can, if you are not very careful, you can mistake an external carotid for an internal carotid. Understood? Now, because we have injected from the common carotid artery, there are vessels overlapping into the internal carotid because these are the branches of the external carotid. This is not, so what is the inference from this? You see a very well, so just enlarge it and see. So this is the common carotid artery, and you have, there is a small irregularity, very smooth irregularity, but we compare here from here, the narrowing is probably to the tune of maybe 10 or 20%. And what is seen here? This is a carotid siphon. So minimal enlargement in the initial part of the proximal internal carotid artery. So what is the conclusion here? So this is the left internal carotid artery. Just compare this with the Doppler report. The Doppler was reported as saying
60 to 70%.
60 to 70%, where you don't see anything here. Is there a carotid web?
No, sir.
No. So this is the gold standard. This is a real picture. This is reality. You are replacing the entire column of blood in the artery with contrast. What you see as black is actually the contrast. So you have, when you give a forceful injection, you replace the column of blood with contrast, and that is imaged as the image. So whatever is column of blood is seen, it is an image which is seen here. So that is the advantage. This is the advantage of doing a digital subtraction angiography. So what have we concluded by this angiogram? The patient does not have a significant carotid stenosis. We'll go to the next image. What is this? Is an AP image. And what is this?
It is internal carotid artery.
Internal carotid artery, and this is the petrous part. The petrous. This is the portion which is inside the petrous bone. So what is the significance of this petrous bone? So this part of the carotid artery is inside a bony canal. This part is inside the bone. So the advantage is this part is relatively stable inside the bone. So if you take a catheter and keep it like this, it will be very stable in this portion, because this portion will not move much. It is inside the bone. Clear?
Yes.
And when you go up, what do you see? This is the AP view. This is the cavernous segment, and this is the top of internal carotid artery dividing into two. This is the A1 continuing as the internal ACA, and this is the M1 dividing into superior division and inferior division. Clear? So suppose if there is a thrombus here, extending here and here, then we call it a T-occlusion. So this is what is a T-occlusion. This is what is many a times people say that the patient has got a T-occlusion. T-occlusion means the distal internal carotid artery is occluded, including the ACA, A1 and the M1. Clear? So what else do you see? There is no stenosis here. For the distal ICA, you have to see the lateral view, and what is this?
It's a right brachiocathode.
So when we are doing the radial image, you make the loop like this with which catheter is this?
SIM1
glide catheter. So you make the curve and then slowly withdraw. When you withdraw, this will automatically go into the you withdraw it and it will automatically go into the right internal carotid, common carotid artery. So what is this white image?
Rod map.
Always remember that is. Always work under a rod map image, which is much easier. You are not blindly taking your catheter anywhere. So you know that the catheter is going into the vessel which you want to take the catheter in. And what is this? Read this. This is the
common
carotid artery dividing into
internal and external.
So this is the external carotid, and this is the internal carotid artery. Clear? This has got branches and it goes up. Clear? This is the petrous segment. We have discussed the petrous segment, and this is the cavernous loop, and it divides into A1. This is A1 and this is M1. Clear? So here also, what do you see? What is the inference? There is no cross flow into the opposite side. So this is, if you take this is exactly ending in the midline. It is not crossing. How will it blood or the contrast? You are injecting contrast into the carotid artery. So what will happen to the contrast? It will flow where blood is flowing. When you inject into the right common carotid artery, it will flow into wherever the blood is flowing. The blood is flowing into the external carotid artery. It is flowing to the internal carotid artery. And here it is not crossing. How will it cross to the opposite side? Through the anterior communicating artery. The anterior communicating artery is not seen here. If it was seen, you would have seen that the opposite ACA is also at least partially filling, depending upon the need. Here it is not crossing to the opposite side. Clear? So the anterior communicating. So what is the inference from this? The circle of Willis is incomplete. So for the circle of Willis to be complete, the ACOM should be there and the PCOM should be there. Then only you have the anterior communicating artery here combining both, and from here you have the posterior communicating artery which is connecting to the posterior cerebral artery. So that will complete the circle of Willis. The advantage of having a complete circle of Willis is if one vessel is occluded, through the circle of Willis, for example, if this A1 is occluded, blood will come through the circle of Willis through the anterior communicating artery and will take care of this. That is the advantage. And if through the posterior communication, suppose if here it is completely occluded. If the circle of Willis is good, from the posterior circulation through the PCOM, it will supply the anterior circulation. So that is the advantage of having a complete circle of Willis. So this is a very interesting digital subtraction angiography study which we have done today. So what is the advantage? What do you think was the main advantage?
The main advantage was we have ruled out a significant
stenosis. The patient does not have a significant carotid stenosis. So that part of the patient doesn't need any specific treatment for that. Second,
we can decide the treatment.
Yeah, he needs to be evaluated by the ophthalmologist and decide what is the treatment to be done for the retinal occlusion. The circle of Willis is incomplete, but he does not have any significant vessel stenosis, so that it may not be significant at this moment. Please do share your comments, thoughts. If you have any opinions to how this can be improved, made more useful for everyone, please do subscribe to this channel as well as share with those who might be interested in learning about cerebral angiogram. Thank you.